Hello guys, today's topic of discussion is diabetic ketoacidosis. Every one of us have been studying diabetic ketoacidosis from so many years, but actually we used to remember diabetic ketoacidosis in a factual manner, like kitna hyperglycemia hai, kitna acidosis hai, etc. But today we will try to understand it in a conceptual manner. So diabetic ketoacidosis. Now it is caused by two reasons. Type 1 diabetes mellitus, type 2 diabetes mellitus. Whenever it is type 1 diabetes mellitus, it is because of either direct diagnosis or not taking insulin or have any trauma. That may be surgical or accidental. Type 2 diabetes mellitus. Now about type 2 diabetes mellitus. Whenever type 2 diabetes mellitus patients have diabetic ketoacidosis, we can say that these patients are long-term diabetic patients or their glucose is not at all maintained at all. And comparatively, type 2 diabetes mellitus is rarer than type 1 diabetes mellitus in terms of having decay. So decay is more common in type 1 diabetes mellitus because type 2 diabetes mellitus will be having a insulin deficiency in mild to moderate range. Mainly they will be having a glucose intolerance, but type 1 diabetes mellitus patients will be having a insulin deficiency very severely. Now let's understand the pathophysiology. As these people have insulin deficiency, whenever insulin deficiency comes, you have to remember two receptors. One is GLUT2 receptor, another is GLUT4 receptor. GLUT2 receptors are present in the pancreas, especially in islet cells. Now let us keep that aside. We'll study about GLUT4 receptors. GLUT4 receptors are present on other cells. I'll name those cells. It is present on other cells. And these cells, GLUT4 will work only if insulin is present. So as in this condition insulin is deficient, those GLUT4 receptor won't work. So the cells can't take the glucose inside. So glucose will be remaining outside and cells will be deficient of glucose. So as GLUT4 don't work, causes blood glucose increase, cellular glucose decrease. Here this we call it as hyperglycemia. It is usually greater than or equal to 250 milligram per deciliter in DKA patients. When cellular glucose decrease, counter-regulatory hormones are activated. I remember these hormones as CAR gate. CAR stands for cortisol, G stands for growth hormone, A stands for adrenaline, T stands for thyroid hormone, E stands for epinephrine. Now these counter-regulatory hormones will act on liver and cause gluconeogenesis and glycogenolysis. Gluconeogenesis means synthesizing glucose from other substances. Glycogenolysis means breaking glycogen. Now, the deficiency of insulin effect is seen in another two areas. One is muscle and another is adipocyte. In muscle, two things will be happening. One is called muscle protein breakdown. Two is Cori's cycle. Muscle protein breakdown will lead to formation of amino acids. Cori's cycle will lead to form lactate. So this both amino acid and lactate will go into gluconeogenesis. This muscle protein breakdown make the body feel the body doesn't have any proteins or the body doesn't have any food. So this causes polyphagia. That is, person will be eating more. Now in adipocyte, we will be having triglycerides. In insulin deficiency, hormone sensitive lipase will be activated. This hormone sensitive lipase breaks the triglyceride into two things. One is glycerol, another is free fatty acids. This free fatty acid also enters into gluconeogenesis. So this gluconeogenesis all takes place in the liver. So all the three processes converge at the liver. Now let's study what happens actually in liver and blood. So we have already studied there will be gluconeogenesis, glycogenolysis. Now liver can't synthesize glucose from all the free fatty acids. So some free fatty acid will be remaining and this free fatty acid will be converted to ketone bodies. So the free fatty acid will be converted to ketone bodies. These ketone bodies are released into circulation. What are the ketone bodies? These are beta hydroxybutyric acid, acetoacetic acid, and acetone. Now remember, these two are acids and this is a gas. Now as these two are acids, they will be releasing the protons, that is H+. Now this proton will undergo three types of changes. I can say two types of changes and one side effect. These protons will be acting on stomach and it can cause nausea and vomiting by irritation. Now the same protons will be entering into peripheral cells. In exchange to these peripheral cells will give out K+, which causes hyperkalemia. So this hyperkalemia you have to remember because this thing will be helping in treatment. Now this same H plus combines with HCO3 minus and leads to formation of H2CO3. This H2CO3 will be breaking down into H2O CO2. So while buffering this, HCO3 level will be decreased. So the level can go till less than 15 milliequivalents per liter. Now this whatever CO2 is formed, it will be removed out in respiration. Now we have studied that ketone bodies are formed. One of them is acetone. The acetone is also gas. This acetone is also removed through respiration, and that leads to having fruity odor. So breath smells like fruity odor. Now there is a term called Kussmaul's breathing. This means rapid and shallow breathing. And why this happens actually? It happens because the same CO2 what is formed, it crosses the blood-brain barrier and it activates the respiratory center. So the respiratory center causes rapid and shallow breathing. Now let us study what are the effects of this diabetic ketoacidosis in nephron. So whenever glucose is increased, it enters the nephron as glucose is hyperosmolar molecule. It drags water with it. So that leads to polyuria. Now this polyuria along with vomiting, we have studied it earlier, together causes dehydration. This dehydration increase osmolarity of blood. So stimulates thirst center. It causes polydipsia. So now we have studied polydipsia, polyphagia, polyuria. Now let us come to treatment part. Now in treatment, we will remember the treatment as four things, that is fluid, drug, fluid, drug. First we will be giving the 2 to 3 liters of normal saline. Once BP starts normalizing, we add 0. 0.1 international unit per kg per hour insulin. This is regular insulin. So once BP reach completely normal, Then we have to add another fluid. I'll say that it is not actually adding. We will replace the previous normal saline with n by 2 saline. Remember, after giving n by 2 normal n by 2 saline, when glucose level starts to reach less than or equal to 250 milligram per deciliter, we have to start dextrose 5% into n by 2 saline. While giving insulin, we always have to remember the potassium levels. These potassium levels, we have to study about two conditions. Once potassium levels reaches 5 to 5.2, we have to better start the potassium drip. If it reaches less than 3.3, stop insulin, start correcting potassium. Once it's corrected, insulin can be given back. Now remember a point that we will treat a patient until his or her anion gap is corrected. Which is high anion gap metabolic acidosis is present in diabetic ketoacidosis, which have to be corrected. Now summary. Hyperglycemia, acidosis, low bicarbonate, ketonemia. So the values are greater than or equal to 250 milligram per deciliter, less than 7.3 pH, less than 15 milliequivalents per deciliter.